My review will be based on largely on educational program, and some of the slides were provided by Dr. Matthias. And the new abstract from ASH and partly from latest guideline by MWG and NCCN. I just made this slide this morning that the major premise is things become different in many ways when we get old. Everything is different. We become fragile. Sometimes the results of the clinical trials are different in elderly population, and the interpretation is different. And if you look at the instance of multiple myeloma, it's considered as a disease of the elderly, and you can easily see the sharp increase in the instance of multiple myeloma over the age 65. And if you look at the median age of a developed country, it is around the 70s. And Asia is not an exception. The median age of multiple myeloma patients in Korea is 67. The interesting thing is, it is correlated with the median age of the population. As you see here, during the 40 years period, median age increased like 20 years in general population, and also the median age of multiple myeloma increased from mid-50s to mid-60s. That means that since the global population is aging, we'll see more and more multiple myeloma elderly patient. And we'll start with the definition of elderly. Traditionally, 65 is a cutoff point, eligible for the allogeneic autologous transplantation. And 75 is another cutoff point until the reduced autotransplantation is feasible. And usually age over 75, and recently 80 is proposed as the reduced conventional therapy. And the population of young population is around only 40%, either in Europe or in Asia. So my talk will be focusing on transplanted ineligible patient only. And if you see this survival figure, strikingly shows that the poor survival of elderly patient. The USCR data is not different. The survival of elderly population is roughly half of a young population. The question is the disease more aggressive in elderly multiple myeloma as it is in AML? There is little evidence. The thing is the patient vulnerable to treatment related to complication? Probably yes. So the reasons of all of this can be speculated in many ways. For example, infection rate is high. Sometimes the patients are not treated because of comorbidity, poor performance status, etc. And the treatment is interrupted from the toxicity, and sometimes delayed the diagnosis. So not only the age, but also the geriatric assessment, such as activity of daily living, or instrumental IDL, or famous Charlson comorbidity index is incorporated in geriatric assessment. The Italian group, this is a proposal of Italian group by Dr. Palombo, and they presented the data that in the last ASH meeting that FRED is an independent prognostic factor, much stronger than even in FISH or ISS. So what is the goal of treatment in elderly multiple myeloma? Of course, it is a prolongation of survival and the delayed disease progression and ensure quality of life. To do this, a maximal cyto reduction is required. Whenever possible, it is the achievement of CR is very important. Of course, it should be balanced with acceptable toxicity. So this largely retrospective study shows that patients who achieved the CR behaved much better than the patients who did not. And this significant overall survival benefit is even observed in very elderly population aged over 75. And this small Spanish study even shows that the deeper the response, for example, immunophenotypic response, is much better than the conventional CR. And in the modern history, the first substance which was believed to be effective in multiple myeloma treatment was comparable to placebo. Coca-Cola was used as a placebo. The curve just looks like that Coca-Cola almost won the race, but however, it was negative. The patient without effective treatment lives like 7 months. MP is the old standard. We know that the MP is the first combination which brings the first meaningful extension of overall survival. However, the response is just around half, and the CR is very rare. In a strict sense, less than 1%, I would say. As a result, long-term survival is quite exception. So during the 20 years, we've done a lot of randomized trials. As you know, there are 27 randomized trials analyzed in a meta-analysis. Was completely negative. It was really a period of frustration. You may be familiar with this curve. You may have seen this curve 100 times, and this curve just shows that how the novel agent improved the multiple myeloma patients significantly. And this benefit is usually seen in young patients, partly from autotransplantation and the novel agent. And while the survival curve of the elderly population had not changed significantly until 2005, I would say. However, if you look at the recent 10 years curve, it is different. The latter half of the last decade is even better than until 2005. And the important thing is the improvement is mainly came from elderly population aged over 65. You know, it was the survival curve. The survival was almost doubled during the past 5 years. So the survival of the MP is slightly more than 2 years, and which improved like this almost 5 months. So in this day, there are a bunch of combinations. The backbone the center is MP. There are many clinical trials. We'll take a look at some of the randomized controlled trials only. I think you're not using the new one. It's okay. It's okay. And let's take a look at the alkylator combinations first. The alkylator means MP or cytoxan plus novel agent, plus Bendamustine. The first and most extensively studied treatment was, as you know, the MPT. There are 6 randomized trials. It is well summarized in a meta-analysis, which show the progression-free survival and overall survival benefit, respectively, 6 months. So MPT became a standard of care. And this curve shows this over 6 months improvement in a meta-analysis. How about the MPV? You are all familiar with the VISTA data. This long-term follow-up, recent published long-term follow-up of VISTA data shows that even though they allow the crossover, the overall survival benefit is persistent after long-term follow-up. It's almost a 1-year gain. The slide sequence is a little bit different. I show you the comparison between MPV and MPT later. How about MPR? Even though we have some subset analysis shows the benefit in progression for free survival in a certain age group, the survival is negative in terms of progression-free survival, which is the primary endpoint of this clinical trial. So MPR at this point is not considered as a standard of care. How about the cytoxan combinations? In this British MRC myeloma 9 study, cytoxan, thalidomide plus dexamethasone shows, although the amount is not big, the significant improvement in progression-free survival. The long-term follow-up shows also confirmed the improvement in progression-free survival and emergent overall survival benefit. So CTD was the commonly used in UK. In United States, although it is not a randomized phase 3 trial, randomized phase 2 study compares the four combinations, and the conclusion was VDC modified is better than VDC, and its variant of Cyborg is very popular in the US. And there was only one Bendamustine trial, phase 3 trial, which shows the higher response rate with the progression-free survival without overall survival benefit. Let's take a look at the non-alkylators, which is IMiD and proteasomes and its combinations. Thalidomide plus dexamethasone TD was not superior to MP in one randomized trial, only one randomized trial. And LD was superior to Lenalidomide with the low dose dexa is superior to Lenalidomide 2 plus high dose dexa in an ECOG trial. You are all familiar with this, I believe. And what is the best pattern for bortezomib? The Spanish study shows that the VMP, they compared the VMP with BTP, which shows the VMP is superior to BTP in terms of overall survival. The extent of survival just presented in last Asia meeting shows the significant change in difference in median overall survival. So their conclusion is VMP is better than BTP. Here's another US study comparing BD versus VMP versus BTD. It's a upfront study. It is also presented in last year's AS meeting, which shows no difference in PFS or overall survival at all, and in terms of toxicity, BD seems to be the best regimen in their conclusion. How about RD and MPT? It is duplicated for some technical reason, as Dr. Lusik already showed us. RD itself is not superior to MPT. Dr. Lusik already also showed this one, and this Italian study shows compare the CPR, which is cytoxin, not carfentanil, versus the MPR versus RD. There's no change, no difference at all, and MPR is more toxic. How about the MPB versus MPT? There is one study just released from American Journal of Hematology. It is available only in abstract form for me. And in this study, European researchers analyzed the 6 MPT trial versus they selected some patient case control study, and what they found was significant higher response CR rate, as well as progression-free survival and overall survival in patients treated with MPB rather than MPT. So MPT seems to be inferior to MPB in their analysis. How about the sequential or alternating? This Spanish study shows that compare the MPB followed by LD or MPB with alternating LD. And this interesting study shows a higher response rate although not significant, high response rate in RD with less toxicity in sequential arms. Should be followed. And I'll skip this one because Dr. Orlowski already showed this. And the last part of my talk will be maintenance treatment, which is one of the hard focus in these days. The earliest and most extensively studied substance studied as a maintenance treatment is, of course, thalidomide. There are more than 6 randomized trials. In most recent analysis, meta-analysis by MIS group showed the later overall survival benefit, as you see here. But the later overall survival benefit is usually seen in transplant group. MRS disease itself they show the significant prolongation of thalidomide users in PFS, but not in overall survival. This is more pronounced in non-intensive arm. In non-intensive arm, there is no change at all in terms of overall survival, confirmed by extended follow-up. The thalidomide maintenance treatment is not so impressive. As you see here, there are mixed positive and negative results. So I would say that at this moment, thalidomide maintenance improved progression-free survival, but overall survival benefit was not well established in elderly population. And the most lenalidomide treatment maintenance was one of the hottest topic in these days. There are five randomized trials until now, and all of the 5 studies, the progression-free survival is increased, and overall survival is kind of mixed. There are 3 trials confirming the overall survival advantage out of 5 trials. And MMO20 was not involved in last year's ASH meta-analysis. And the meta-analysis shows a significant prolongation of progression-free survival, but marginal, the p-value is 0.07. And this is MM015 study Dr. Orlowski already showed us. But to me, the progression-free survival is increased in MPR with R maintenance, as you see here. But overall survival is quite impressive. Although it is the curve were not separated, overall survival is around 56 months, which is comparable with MPV, I think. And first, the study is a duplication of post-technical lesion. I skipped this one. The progression-free survival was increased, and as well as overall survival. And SPM, second primary malignancy issue is one of the hottest topics in these days. And as you see here, the odds ratio is very high in young population, but it is not impressive in elderly trials, including 2 trials. So I would say increased SPM is not evident at this moment in the elderly population. And finally, the Velcade plus thalidomide maintenance, this Italian study comparing BMPT followed by BT shows clearly, it is a long-term follow-up data. It clearly shows the overall survival benefit over MPT alone, BMP alone. So, can we do some tailored therapy? There are some suggestions. This is just one of the examples that we can tailor therapy according to patient status, like fit or unfit. Unfit, I'm not going to go in there in detail. So my conclusion, my summary is novel agent-based combinations actually double the survival in these days, and are the currently standard care. And maintenance therapy, especially Revlimid and Velcade maintenance, is becoming more important. And we need simple and standard geriatric assessment that is reproducible. And numerous ongoing trials, including new proteasome inhibitor, the trials will answer the optimal induction treatment schedule and route of delivery. Thank you for your attention.